Hello, and welcome to All Things Breastfeeding, where we discuss happenings around the breastfeeding world. I am Barbara Robertson. I'm your host of All Things Breastfeeding. I'm the owner of Lacta and I am here today. I'm joined by Miena Hall, and I'm going to read your bio so that I can introduce you. So you're an MD, you're an NABBLM-C. We'll get into that in a minute. IBCLC, a breastfeeding and lactation medicine physician and researcher in the suburbs of Chicago. She's the director of scientific affairs at the Mother's Milk Bank of the Western Great Lakes and practices medicine at her private clinic, Lactation MD. Her research focuses on the longitudinal imaging of fibroglandular tissue during pregnancy. Well, she'll discuss that. The composition of donor human milk and the development of breastfeeding knowledgeable health systems. Dr. Hall also teaches medical students at Loyola University, Chicago Stritch School of Medicine, and the University of Illinois at Chicago College of Medicine. She credits her multiple breastfeeding journeys with her 4 children and the aid which she received as her continuing inspiration to help lactating diets in need. Well, welcome, Anna,
Thank you,
to our
Barbara.
podcast. All right, so tell us a little bit about the NABBLM-C.
Yes,
That's an
yes,
abbreviation I haven't heard of yet.
yes. So that stands for the North American Board of Breastfeeding and Lactation Medicine. Um, so North American, so it's jointly between the United States and Canada,
Mm,
and so it is now essentially offering board certification
oh,
for breastfeeding and lactation medicine physicians. Because physician and then advanced practice provider credentialing is as typically certification is typically different. That's
mhm.
kind of why it only exists for physicians at this point in time. My understanding is that other advanced practice nurses are working on this type of certification for themselves, but it means essentially then that a physician has done enough hours and of training, has passed a rigorous board exam, and that they are prepared to take care of lactating dyads where when there's a medical need which arises.
Wonderful. And I think something that is very unique about your story and your journey, and we're going to talk about that in just a second, is the intentionality of your focus. And you always, it sounds like always intended to become a breastfeeding medicine doctor. That's
Yes.
kind of, yeah. So tell us about your journey. So how did you start? You mentioned your 4 kids. A lot of us, that's how we got our start. Sometimes it was because you had a great experience. Sometimes because you had a bad experience. So what was the beginning of your journey?
Yeah, so beginning of the journey, you will say kind of take back, even as a child, I knew that
Mhm.
I wanted to help people, right? And what better way as a child do you see of helping people other than as your doctor, right? For
Mhm.
me, I had a pediatrician. I am a family doc though, by
Mhm.
training, so I could have had a family doc, but I was taken to a pediatrician, and it was such a warm and caring experience. And then growing up, I was thinking that's what I wanted to do,
Okay.
but ended up kind of did all the pre-med things, but then I married my high school sweetheart and we started our family.
Yeah.
So
Mhm.
so then thrown into, how do I breastfeed this child? And it was I had a rough go in the beginning, and my salvation was La Leche League.
Yeah.
And so that's actually where I met Nancy Moorbacher, was
Mhm.
through La Leche League in the suburbs of Chicago. And just it was not anything that I had learned about growing up, how to breastfeed, but it was kind of something I always assumed I would do.
Right.
And just learning, you spend all of these years studying, going to school, and it trains a completely different part of your brain than the brain you need to become a breastfeeding mother.
Mhm.
And so I just really wholeheartedly embraced it.
Mhm.
And because I do like to teach,
Mhm.
it was wonderful to then I became the librarian of my group.
Mhm.
And then one of the leaders said, well, had you considered becoming a leader?
Yeah.
Why you maybe step into this leader applicant space? And so then after becoming a leader, and having subsequent children, and just kind of realizing now physicians were always supportive of breastfeeding, but oftentimes they didn't know very much.
Right.
So
Yeah.
I had an OB with my eldest child, and then I had family medicine doctor who delivered the middle two, and then I had a midwife for the youngest.
Mm-hmm.
And the OB was also pregnant at the same time as I was pregnant. She was due 2 months later.
Mm-hmm.
When I came to, my 6 week postpartum checkup, she was asking me questions about how
Yeah.
breastfeeding happened, and I was just surprised to learn she had no knowledge about breastfeeding that she had acquired during medical school or residency.
Mm-hmm. Yeah.
So and then pediatrician essentially very, very supportive for my eldest child, but again, didn't know anything about what beyond what his own wife had learned
Mm-hmm.
when breastfeeding their first child.
That is such a problem, is so many doctors are basing their knowledge upon either their personal experience or their partner's experience
Absolutely.
rather than what does the research say. And, I think about orthopedics and I'm always like, yeah, if my arm is broken, I don't think you're going to say, well, when my wife's arm was broken, you know,
Precisely.
but we do that. The peer-to-peer background that you have, I think, is important. That's something you and Nancy and I all have is that peer-to-peer support. And it is interesting the power of that support group. I don't know about you, but I went once a month. I went from a disaster situation to turning everything around and then nursing for 3 years,
Oh,
you know,
wonderful.
with the first. But the support that I got from the group that I went to once a month, one time a month, was enough to give me confidence and turn things around.
Absolutely.
Yeah, yeah. So that's an interesting. Well, hopefully we'll circle back to where support groups fit into your life now. Okay, so you were an IB, you became a La Leche League leader, peer to support. So then what happened next? What were the
Yeah,
next
so
steps in your
so
journey?
then so La Leche League leader, and then I kind of came to a crossroads. At that point in time, one could sit for the IBLCE after having been a leader for 5 years.
Right.
Okay.
That's what I
And
did too.
and so then sort of asking myself, well, how are people going to pay me? Is it going to be out of pocket? This is before Obamacare. This is before
Right.
lactation was covered.
Yeah.
So, how am I going to get reimbursed?
Hmm.
And then at that point in time, some of the other networks who bill on behalf of IBCLCs had not yet come to fruition.
Right.
So I was sort of faced with this crossroads of do I want to become potentially, I was thinking really strongly about becoming an RN and then
Hmm.
eventually becoming an advanced practice nurse. That was really what I was thinking strongly
Hmm.
about. But then I ended up going to an informational session for a bachelor's to RN degree, and there was actually an anesthesiologist there running one of the informational meetings. And when he saw my background and the education I'd already had done in a
Hmm.
pre-med track, he
Hmm.
recommended that I would be better off
Hmm.
rather than potentially having to retake coursework because it was more than 5 years old,
Hmm.
study on my own, apply to medical school, and then eventually become the type of physician that I wanted to be because
Hmm.
you have tremendous autonomy to practice medicine how you want to practice.
Right.
So that was his recommendation, and that's really what steered me down this path. Is that I was able to be accepted to medical school. And so I made the choice actually to not sit for my IBCLC until I was within finishing my residency because I'm going to pay the money, I'm going to pay the $400
Right.
at
Right.
that point in time, but I'm not going to be able to use it.
No, because you're
So
too busy with medical school to
precisely,
take the time.
precisely. So, but you have to figure out, okay, I'm going to be done in June of 2021.
Mhm.
Therefore, I'm going to need to sit for it in the fall of 2020 so that by the time 21 comes around, I'm good to go when once I'm
Mhm.
at my first job in July.
Mhm. So you felt it was really important to be an IBCLC and an MD.
Absolutely,
Talk
because
about talk
that,
about that.
yeah. So medicine is tremendous. The amount that you learn in medical school and residency boggles my mind. I have many friends who are physicians, okay? No close family members, but many friends. And the volume of information that you have to learn. So just an example would be a year-long biochemistry course that someone might take as a senior in college. We needed to cover in in 6 months in medical school. And that was in addition to having a full, anatomy class, which covered the entire year,
Mhm.
physiology, you
Yeah.
know, all of these different courses that you needed to take. So it was a tremendous amount of work all the time. We were literally in the classroom or the lab 50 hours a week,
Hmm.
every single week.
Yeah.
Is just so much to learn. But yet there was one lecture on breastfeeding, right?
Right.
Breastfeeding and
Yeah.
lactation. So many lectures on the pathophysiology of the breast related to breast
Mhm.
cancer, but
Mm.
very, very limited things. So all of the things that I would say that I bring in terms of normal
Mhm.
breastfeeding and how, pump fittings, for example, those are things that I learned as a La Leche League leader and in with the mentorship that I received that got me ready for the IBLCE.
Hmm.
So
Yeah.
there are now fellowships that are available. So I have participated in a 2-year clinical fellowship at the University of Rochester. That's now a new offering where someone would get that type of training in addition to their medical training. But prior to this, and I was a member of the first cohort, there's just not really an avenue for a physician who's interested in learning about breastfeeding and lactation to get it other than working with IBCLCs.
Hmm. Well, they say, to me and my IBCLCs, I have a master's in education, and it was just like another master's degree for me. I had to take some college courses. I definitely was the clinical hours that were the biggest piece. Yeah, and it takes time and to see all those dyads and get that experience, which is critical. Okay, so now you are an IBCLC, you're an MD, family practice doctor. Um, I think that there's a lot of tension in the field of lactation, or maybe it's perceived, maybe it's made up tension between doctors and IBCLCs. Like it's almost like it feels like there's competition for the money because I think we're all kind of trying to chase money and be able to make a living off of something that we love. And so, what do you think about this idea of doctor versus IBCLC?
I think that's a great question. So, and I feel that tension. And even though, one of the roles that I played within the Leche League is I was actually the area coordinator of leaders for the state of Illinois for several
Mhm.
years. So I know so many of the current lactation consultants who work in the Chicagoland area. I've known them for over 20 years at this point. And that there can be some tension, right? Because as part of my exams, I'm oftentimes will say sort of rechecking their work. But I
Mhm.
would want the same for any
Right.
of my patients, right? Like if I'm one individual and just because I have an MD after my name doesn't mean that I haven't missed something, right?
Mhm.
I have
Right.
20 years of experience within the lactation space doesn't mean that I haven't missed something.
Mhm.
So there's sometimes I think we all as humans sometimes have egos which are butting heads, right?
Mhm.
But there's so much ability. There are so many people who need cared for,
Right.
right? And there are so many times when things are dynamic and they're changing. And what I see one day, the next day somebody sees something completely different.
Mhm.
Okay. Especially within lactation, that I think it's good for us to remember that we can work together. And I really feel like it's a synergistic relationship. And so
Mhm.
I have dyads who come to see me in person, and then they're still seeing their own IBCLC at home. I
Mhm.
have people where we have maybe more the IBCLC and I have a closer working relationship. And
Mhm.
so we will have conversations, we'll pick up the phone, we'll talk to each other about, okay, this is what I saw. I'm faxing you my report. What
Mhm.
did you see? This is what I saw. These are my
Mhm.
recommendations. I would say flange fittings end up being the most contentious issue, but I think
Mhm.
that's one of the things that's most dynamic, honestly. And I think we have honestly the least. We still have so much research to do on that
Yeah.
in terms of what's the ideal way to fit flanges.
Mm-hmm.
And so that's something where it goes back and forth. This is kind of what I'm seeing. What are you
Mm-hmm.
seeing? Can we talk with the patient, with the dyad? Like how are things changing?
Right.
I
That's
feel
really
like
good
it's
question. Yeah.
yeah. I feel
That's
like
what
it's
we're
a
thinking about.
very strong opportunity for
Yeah.
collaboration because of the way insurance is now starting to reimburse for lactation.
Yeah, let's pause just for a second. So
Sure.
because you have set up an office that very much incorporates IBCLCs. So
Yes.
you do have people who come from the outside that all have their own IBCLC, but you also have you can take care of everything in-house at Lactation MD, your business,
That's correct.
your doctor's office. So talk about how you set that up and what it looks like.
Yeah. So what we are getting a good number of referrals from people who have never seen an IBCLC before.
Right.
And so those are the people in general at this point in time who are seeing an IBCLC in office
Hmm.
independently of me, or we
Hmm.
have some IBCLCs who will go to, the adjacent, neighboring communities and do home visits
Hmm.
for the first 6 weeks
Wonderful.
postpartum. But then we cap it at six
Hmm.
weeks.
Yeah.
And we ask people to come to the office.
Hmm.
But the goal is then that they are developing that primary relationship with their IBCLC, and I am almost a consultant to the
Hmm.
IBCLC. And then similarly, if someone already has their own IBCLC who has referred them, I am working as a consultant for that IBCLC.
Hmm.
We're working to take care of that dyad together.
Hmm.
And sometimes, depending on, kind of my situation in the office, if someone's coming in for and I do scissor frenotomy. So if someone's coming in for a tongue tie evaluation, and
Hmm.
I'm going to be assisted by an IBCLC who's in the office because
Hmm.
unfortunately, again, insurance is reimbursing me as if I'm a family medicine doctor. And so
Hmm.
they're thinking that I need to see 3.5 patients per hour in order to pay
Right. Right.
for salary and overhead, this
Hmm.
entire, space.
Hmm.
So, I would say like we run a lean operation, but the goal is to make sure that everybody is reimbursed appropriate to the time that they're spending in the
Hmm.
office, the level of care that they are providing, et cetera. But again, insurance is saying we will pay for lactation, but we won't pay that to a physician. So
Right.
the codes that an IBCLC who's working with me that we can bill for them are not the codes that I can use when
Hmm.
I'm caring for dyads. So it really is looking at me as, kind of staying in that physician lane, which is
Hmm.
actually allows me to care for more dyads that way. So
Yeah. Well, we were talking earlier about this, and you brought up a very interesting point that was a surprise to you, which is the role delineation. Like you didn't expect, you had hoped to be a little more casual in your work.
I had hoped to be a little bit more casual in my work. I really appreciated the fact that you introduced me as Miena Hall, because sometimes I think the appellation of doctor is daunting to
Mhm.
people.
Yeah.
One of the reasons I don't wear a white coat is because white coat hypertension really is a
Hmm.
thing,
It
and
really
people
is. Yeah.
very much can have a positive relationship with a
Hmm.
physician, or they could have a very strong negative association with a physician. And
Hmm.
because lactation is a very emotional experience for people,
Hmm.
I wanted to try to create a space that's as warm and homey. Like our exam rooms, they have couches in them,
Right.
right? They don't look like doctor office rooms. And
Hmm.
that is intentional.
Hmm.
But when we try to kind of all be wearing the same uniform, it was
Hmm.
confusing for patients because they
Hmm.
would be saying, okay, I know that I came here to see Dr. Hall, but
Hmm.
now this is Dr. Hall.
Yeah.
Dr.
Is
Hall doesn't
who is
look
Dr.
like the
Hall?
role. Yeah,
Right.
who is Dr. Hall? Especially one of my lactation consultants and I have about the same haircut and coloring. So it could be very, very confusing for people.
Ah, okay. And so, yeah, so what did you end up doing that was a compromise, so that people could recognize you as the doctor and feel like they've seen the doctor?
Yes.
Yeah, so what did you do?
Yeah, so I love pink. So the theme in
Hmm.
my office is pink, right?
Hmm.
So essentially I typically wear something that's business casual,
Hmm.
and it usually has some pink element to it.
Hmm.
And then I have a long pink cardigan. that I
Mm-hmm.
typically wear,
Mm-hmm.
and the pink cardigan being the nod to the white coat. So then
Mm-hmm.
that gives people that to anchor on, but I
Mm-hmm.
think it's not potentially as triggering for individuals when
Yeah.
they're thinking of, a physician whom they might be afraid of. So,
Yeah. So you've indicated you're the doctor, but not a scary doctor.
right,
So
right,
good work.
exactly.
Good work. All
Thank you.
right. Well, and so you're finding that the partnership of IBCLCs and MDs is working beautifully, because of the way insurance has set you up in many ways and the
Correct.
billing process. It's all about billing, right?
It
I think when we
is.
both became IBCLCs, I would hand people a super bill and say good luck, because I couldn't possibly deal with the billing myself.
Right.
And so, I was trying to help them out if they wanted to seek reimbursement, but it was difficult. So now there are ways for IBCLCs to get reimbursement through insurance.
Mhm.
And that one of the things that you said is they can spend more time. And you've talked about kind of that they have the personal connection. So again, that heart. So talk a little bit about their role as a nurturer versus your role as a doctor. And do you miss that? Do you miss that role as the
I
nurturer?
I do miss that role as the nurturer. Sometimes it happens if someone has seen multiple lactation consultants and they are coming and they don't have someone that with whom they are actively working, and they specifically call and they say, "I want to see
Yeah.
Dr. Hall."
Hmm.
Dr. Hall will perform the entire visit. And do I get reimbursed in the way as wearing both the IBCLC and the physician hat? I don't. But
Right.
patient care and the relationship that they are looking for,
Hmm.
that's what's important to me.
Hmm.
And so then I will wear both hats.
Hmm.
But typically though, we unfortunately have to separate those because otherwise, we're not reimbursed. I am not reimbursed for my time.
Hmm.
And so the the IBCLC role is that nurturing role. It's that opportunity to be essentially akin to a peer, and a
Right.
physician by the way that medicine has evolved is
Hmm.
not. We
Hmm.
have a lot more uh, discussions, right? Like it's not directive in the same way, at least with my medical training, we're
Right.
not to be directive or paternalistic,
Hmm.
but there's still hierarchy and there's still that feeling the buck stops here. You are still the
Hmm.
doctor.
Hmm.
Yes, the patient can ultimately say, these are the things that I want to do, but as the clinician, you need to be able to say, I hear you, I understand,
Hmm.
I'm there for you, but we have to do this. If
Hmm.
someone comes in and is a diabetic and
Hmm.
they have a very, very high A1C and they're very afraid of needles, but they have to use insulin, you
Hmm.
are obligated to do no harm. You have to tell them you
Hmm.
must take this insulin or these things may are going to happen to you,
Right. Right.
right?
Yeah. Yeah. It's interesting though, thinking back to I'm fascinated by behavior change, and we are more likely to listen to and believe our peers, which is why I think one of the reasons a support group model is so powerful because we
Absolutely.
trust that parent sitting there with a baby who's 3 weeks older than ours more than the experts. And so you do have a beautiful balance of like the peer support and but then also the doctor being able to come in and say here are like some medical facts that
Right.
that we need to pay attention to.
Yes, yes. I'm sorry, but you are going to have to take these antibiotics because we're not going to heal that wound,
Right,
right? Like
exactly.
you
Coming
sometimes
down to,
that has to be, and that does not necessarily happen when it's peer to peer.
yeah. So what are some of the most important things that you feel like an MD can do, a family practice doctor, versus an IBCLC? And then we're going to switch it.
Yeah, absolutely. So in terms of what as a physician now that I'm able to do that I wasn't able to do if I had gone from La Leche League to IBCLC, I am able to I'm able to diagnose. So
Right.
an IBCLC can describe, right?
Mm-hmm.
And so it's fabulous when I get these amazing descriptions from the people who have been supporting these dietats because that makes my life so much easier.
Mm-hmm.
But it's not within the wheelhouse of IBCLC to diagnose. It's not
Right.
within the IBCLC's wheelhouse to prescribe, to
Hmm.
order tests, to
Right.
order imaging. These are
Hmm.
all things that I can do now as a physician, or that I could have done as an advanced practice provider.
Hmm.
The other things, I can perform procedures. So I do
Hmm.
scissor
Right.
frenotomies in the office.
Hmm.
I will also, so lingual frenotomy, so under the tongue, I will do
Hmm.
labial frenotomies for lip ties. I can also drain breast abscesses.
Right. Right.
So, and we're a year into the practice, but the goal is also to purchase a handheld ultrasound probe. So then
Mm-hmm.
I would be able to do even, more potential abscess drainages in the office. Those
Hmm.
are skills that I would not be permitted to do as an IBCLC.
Hmm.
Uh, and then beyond that, I do still enjoy doing primary care. So that
Hmm.
is kind of bread and butter of doing the family medicine training, which was again also very intentional,
Hmm.
to pick family medicine versus pediatrics or OB-GYN,
Hmm.
into moving to this breastfeeding and lactation medicine space.
Hmm.
So I can do pediatric care,
Hmm.
0 to age 21, we'll say, but as a
Hmm.
family medicine doctor, you take care of everyone 0 to
Yeah.
120, I
Right.
suppose.
Right.
Um, but so then I'm able to, for families who choose to stay with me, I can become their primary pediatric provider. I
Hmm.
take care of the parents, I take
Hmm.
care of the mom, I take care of the dad, take care of,
Hmm.
it's I don't take uh, Medicare, so I don't take care of anyone then who would be 65 and older unless they have
Hmm.
their self-pay or private
Hmm.
insurance. So those
Hmm.
are all things I still function as a primary care physician.
Yeah. Okay, so what are some of the things that you feel like an IBCLC can do? And a lot of it has to do with billing and insurance that an MD cannot, a family practice cannot do.
Yes. A family practice cannot afford to spend 75 to 90 minutes with a dyad.
Right.
Okay.
It just, you can't.
You just can't. You can't afford to keep the lights on. You can't have front desk staff. You can't
Hmm.
have a medical assistant. You can't have a nurse.
Hmm.
Uh, these, the way that insurance payers reimburse is based on volume. And
Yeah.
so you have to see 3.5
Mm.
level 4 visits in order to pay yourself the salary that sort of you expect,
Hmm.
and to keep the lights on and to pay
Yeah.
for your staff appropriately.
Right.
So it unfortunately comes down to the dollars and cents. And so um, I lose money when I work as an IBCLC, which
Hmm.
is heartbreaking to say,
Right.
right? But it's
But it's
just
a
the bottom
fact.
line. It's just a
It-
fact.
yeah, it's our medical system and it's just a fact. And so the IBCLCs allow you to practice as a breastfeeding medicine doctor
Yes,
in many ways. Would you say that's true? Yeah.
absolutely,
Yeah. So
absolutely,
again, that partnership versus a competition.
absolutely.
All right. Well, I think that, that's you've got so much more we could talk about. We might have to do another podcast because I do want to talk about your research, but we don't have time to get into that for that. But especially the work that you've been doing with the fibroglandular tissue.
Yeah, so that's
That's been
specifically
fascinating.
related to IGT, insufficient glandular tissue, because
So
we
yeah,
need
we're
to
gonna
have screening tools to identify this early and help people get prepared for it, and then maybe
right.
in the future have actual treatment options.
Right. Because right now we're kind of looking and we're like, okay, we're going to watch you carefully during that first week. That's our answer is,
Right.
just really keeping a good eye on the baby and the milk transfer and how things are going. So
Yes.
we're going to have to pause on that, but we'll do another podcast on that because that is an absolutely fascinating study. And you have your work with the milk bank too. Well,
Yes.
thank you. Other
Absolutely.
like ending comments that you wanna conclude with? Anything you feel like to say?
Yeah, I mean, I think that the ability for for IBCLCs and breastfeeding and lactation medicine physicians, because there really aren't a lot of us in the United States and
No, they're not.
Canada, like there's tremendous collaborative opportunities here.
Hmm.
Um, and but I think it requires the ability to because there were times when I was a stay-at-home mother where I would feel that frustration of, working as a literature league leader and having another physician tell someone that they had to stop
Right.
breastfeeding in order
I
to
know.
take this medication, right? And I'd be like, ah, I'm tearing my hair out, kind of thing.
Right. Right.
But then being on the flip side, having had medical training, now I understand where you're trying to see so many patients and
Yeah.
do so many things and be pulled in so many different directions. It's hard to have the time to
Mhm.
be able to take the time to look something up that you didn't learn
Mhm.
already in your
Right.
training. And now it's a lot easier. We can have an app. But if people don't know that the app exists to look something up, or they don't know that NIH, has lactation medication resources, they're going to default to the most protective thing for them. And based on what they know, to tell someone that unfortunately, all too often, breastfeeding is the thing that is least important
Right.
somehow. Okay,
Yeah.
even though it really should be of paramount importance. But if someone has an infection and it needs to be treated, let's treat the infection so that they don't become septic, right? Like that's the way that the medical mind is trained to think.
Mhm.
So, but and this is why medical student education is so important to me, is when I train young, future physicians, and I let them know this is how lactation, this is the physiology of lactation, this is the pathophysiology of lactation. These are the resources that you have in the future that are going to be updated continually for you, so that you don't need to tell someone that they have to stop breastfeeding in order to take a medication, or that they have to pump and dump. This is where you look it up. They're going to remember that and they're going to use it in the future. And it's unfortunate. Medical training takes so long and we stay in the system for so long. We don't necessarily learn new tools if they're not out there being
Mhm.
advertised for us. So that's where it's, get the learning out there, try to tell people out there, but just reminding families and patients that most physicians did not go into this for the money kind of thing. They
Mhm.
went into it for the goodness of their hearts, and they're not trying to and they're not trying to prevent people from breastfeeding. Their resources are very, very limited, and they're doing the best that they can with what they've got.
Absolutely. Absolutely. Well, thank you again for joining me, and we will talk to you again in the future, again about your research. Thank all of you for listening. This is again all things breastfeeding. If you're enjoying our podcast, if you could leave us a review on your favorite podcast listening device, would very much appreciate it, so other families can find us. All right. Well, again, thank you for your time. We
It was a
appreciate
pleasure.
having you
Thank you,
here,
Barbara.
and take care.